Nausea. We've all been there, and it's a universally awful feeling. But the ways we can fight it are incredibly specific and, honestly, pretty cool. So today, we're going to break down the science behind the most common anti-nausea meds and see exactly how they work inside our body's control center.
Okay, so let's just dive right in. Where does that awful feeling really come from? You'd think it's all happening in your stomach, right? Well, not exactly. The real command center is actually up in your brain. And as you'll see, it's not just one big red nausea button, but a whole complex system of triggers and alarms.
To get how these drugs work, we first need to meet the vomiting center. It's located deep in your brainstem, in a spot called the medulla. Now, think of this place as the main security hub for nausea. It doesn't just go off on its own. It sits there and waits for alarm signals to come pouring in.
So this control center is basically a high-tech security room that gets alerts from four main sources. First up, you've got the chemoreceptor trigger zone, or CTZ, which is constantly tasting your blood for any toxins or chemicals that shouldn't be there. Then there's your vestibular system, your inner ear, that reports on motion. Third, your GI tract itself can send up a flare when it's irritated. And finally, and this is wild, your cerebral cortex can trigger nausea just from thinking about something gross or from sheer anxiety.
Okay, so that's the problem. What about the solutions? Let's start with one of the most common, a real first-line defense, Ondansetron, which you might know as Zofra.
Its official class, a 5-HT3 receptor antagonist, sounds complicated, but it tells us exactly what it does. The key word here is antagonist. That just means it's a blocker. It's designed to block the docking stations for a chemical messenger called serotonin, which is a huge player in sending those nausea signals from the gut to the brain.
So, picture this. After something like chemotherapy or surgery, your gut gets stressed out and releases a flood of serotonin. This serotonin zips up to the brain's CTZ and basically starts screaming, "Alarm! Alarm!" Well, Ondansetron steps in and, metaphorically, puts a pair of noise-canceling headphones on those receptors. The alarm is still ringing, but the brain's control center just can't hear it. The signal is blocked, and the feeling of nausea is prevented.
Because of how it works, it is a fantastic tool for nausea caused by chemo or surgery. But there's a really big catch. It can mess with the heart's electrical rhythm. It's an issue known as QT prolongation, which basically means it delays the heart's ability to recharge between beats. And that can be especially risky for patients who already have heart conditions.
All right, our next tool, Metoclopramide, is fascinating because it has this dual-action approach. It doesn't just block a signal, it also helps fix the physical problem down in the gut.
Again, the class name tells the whole story. It's a dopamine D2 antagonist, so it blocks dopamine signals in the brain's nausea center, but it's also a prokinetic. That's just a fancy way of saying it gets the gut moving along, helping the stomach to empty itself out.
Think of it like a two-pronged attack. It's silencing the alarm upstairs by blocking dopamine, while at the same time, it's addressing the traffic jam downstairs by getting the stomach to clear out. It's a really unique approach.
This makes it incredibly valuable for conditions where the stomach is emptying too slowly. But, and this is a big one, blocking dopamine in the brain comes with a significant risk. It can cause some really scary movement disorders, known as extrapyramidal symptoms, or EPS. This can look like sudden muscle spasms or an intense restlessness.
Now, this side effect is so important that we really need to take a quick look at it. So, what exactly is EPS? And more importantly, if it happens, how can it be managed? Okay, now what's really interesting here is that the fix is another super common drug you probably have in your medicine cabinet, Diphenhydramine, Benadryl. See, metoclopramide causes the problem by blocking dopamine, which throws off this delicate balance between dopamine and another chemical called acetylcholine. Benadryl, with its anticholinergic properties, swoops in and helps restore that balance, which can quickly reverse those scary muscle reactions. Pretty cool, huh?
Next up, we have a real specialist. This one is purpose-built from nausea that comes from motion. When a bumpy car ride or a rocky boat just overwhelms your system. For that, the go-to tool is Scopolamine.
This drug often comes in a simple little patch you stick behind your ear. It's an anticholinergic, which means it works by blocking acetylcholine signals coming directly from the vestibular system, your body's motion and balance sensor. It basically stops the motion sickness signal right at the source. It works incredibly well for that cruise or that long car trip, but its side effects like dry mouth and blurred vision are pretty potent. And you have to be especially careful with older patients because it can cause some pretty significant confusion or even delirium.
Okay, finally, let's cover two important supporting players in the anti-nausea world. These aren't usually the first drugs you reach for, but they play absolutely crucial roles in very specific situations.
First is dexamethasone. This is a steroid, and it's not really for the nausea you're feeling right now. Instead, its job is to be a powerhouse for preventing the nausea that can sneak up on you a day or two after a chemotherapy treatment. It's a vital part of the preventative toolkit, but it can mess with your sleep and raise blood sugar levels.
And this last one is just brilliant, because it shows how we can treat nausea that hasn't even physically started yet. Lorazepam is for what's called anticipatory nausea, the kind that starts in your cerebral cortex. It calms the anxiety and fear a person might feel before a treatment even begins, stopping that signal from ever getting sent to the vomiting center. Of course, the trade-offs are pretty significant: sedation and a risk of dependence.
So how does this all come together? When you put it all out there, it becomes clear that it's all about matching the right drug to the right nausea pathway. Let's put our whole toolbox together. This one table really synthesizes our entire explainer. It shows that there's a specific key for each lock. You've got Ondansetron for those big serotonin surges from chemo, Metoclopramide when the gut is sluggish, Scopolamine for motion sickness, and our helpers, Dexamethasone and Lorazepam, for the delayed and anxiety-driven stuff. Each one targets a different alarm signal heading to the brain's control center.
You know, understanding these specific mechanisms isn't just academic, it's everything. By knowing whether the alarm is coming from the gut, the inner ear, or even from our own thoughts, we can choose the exact right tool to silence it. And that paves the way for much more personalized, more effective treatments, and ultimately a future with way better control over this fundamental human experience.